You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 1st, 2020. Today I'm talking COVID, but also cardiology sneaks in. Let's first go over the COVID numbers in the U.S. When I recorded last week, there were 880,000 cases. Today, there are 1.1 million cases. So the rate of rise last week was 1.30x, and this week it is 1.25x. Again, a decrease, but given the massive ramp up in testing, an encouraging sign. The death numbers, however, are what they are. When I recorded last week, there were 50,000 deaths in the U.S., and today there are 63,000. The rate of rise last week was 1.6x, but now it has decreased to 1.25x. SARS-CoV-2 will cause people to die. It's nobody's fault. Well, thank goodness more than 99% of people who get this disease do not die. The big news worldwide is that we now have more than 1 million cases recovered. I received a comment on the site complaining that I talk too much about COVID and too little about cardiology, and this week I'm going to rectify that. But first, COVID news. This week, our governor here in Kentucky and our hospitals have decided to start doing some semi-elective cases. This is good because our hospital sits about half empty. The number of COVID patients has declined, as has the number in the ICU. I've been following the UCSF in San Francisco. They too have decreasing numbers. My friend Vinay Prasad tells me that his hospital in Oregon is more than half empty. And on my e-group with American electrophysiologists, they tell the same story. Even colleagues in New York say things are much better. So I think we must start framing things correctly. The virus is not going to disappear. It's a coronavirus. We will be dealing with this for years, perhaps forever. It will always be dangerous to older people and those who have significant comorbid conditions. Now, I know I have many listeners in many parts of the world, and I want to be clear. I'm not saying social distancing is wrong or that we simply go back to the pre-COVID days. But staying locked up and economically shut down as we are now is not sustainable without causing much more non-COVID morbidity and mortality. I have a short column coming out today, and I hope you take a look at it, in which I discuss the harms or the potential harms of our interventions. I cite a new preprint from a group in Glasgow, Scotland, part of the group of Professor John McMurray. Okay, second topic on COVID is remdesivir. Results of 2 randomized controlled trials of remdesivir were released this week. First, the Dr. Fauci report of an NIH-sponsored double-blind RCT called Adaptive COVID-19 Treatment Trial, or ACTT trial, which began enrolling in Nebraska in February. While he was sitting on a gold couch in the Oval Office of the White House, Dr. Fauci gave an incredibly brilliant 5-minute non-PowerPoint presentation. He said that the remdesivir had outperformed placebo. Patients who received remdesivir had a 31% faster time to recovery than those who received placebo. The median time to recovery was 11 days in the remdesivir group versus 15 in placebo. And there was a survival benefit, or a trend towards survival benefit, with a mortality rate of 8% in remdesivir versus 11.6 for the placebo group. The p-value was 0.06. Now, one fly in the ointment of this NIH trial, as noted by Dr. Walid Gilad on Twitter, was that the outcomes measure for the trial were changed. The primary endpoint of the trial was originally an 8-point severity scale, but 2 weeks ago was changed to time to recovery. Now, once this got on Twitter, the NIH sent an explanation for the change, citing 1, little was known about the disease when the trial started in February, 2, concerns had arisen about relying on a single time point, and 3, blinding had remained from the investigators. This is all we have as of Friday morning, 4 days after the DSMB reviewed the data. There's no preprint, there's no paper, we don't know the baseline characteristics of the patients, we don't know adverse events or data on dropouts. Notably though, I have to report 2 extremely thoughtful academics have weighed in. Professor Rod Hayward from Michigan and Daryl Francis from London have both written that given the priors and the effect size and the stature of the NIH researchers, they believe the drug has a real effect. I would like to see the paper. I mean, a 3% effect size for mortality is big, but the problem is that with a p-value of 0.06, you certainly have the possibility that these results could have been observed in the absence of a remdesivir effect, in other words, by chance. Now, the second RCT, which was done in China, published in Lancet, had 237 patients, but it had to be halted due to the fact that there were not enough patients to recruit. Patients in this trial had 12 days of symptoms, confirmed viral infection, infiltrates, and the saturation less than 94%, so they were sick. This trial found no reduction in time to clinical improvement and no mortality reduction. Importantly, the Chinese investigators had checked the viral load, and remdesivir had no effect compared to placebo. Now, the thing is, if you had just seen this trial, you would be unimpressed. But Dr. Fauci's glowing presentation on that gold couch came on the same day the Lancet paper had come out. Fauci was asked about the Chinese trial, and he called it underpowered. So there you have it, a great lesson in cardiology. The huge effect size in the NIH trial could be a type 1 error, a false positive. And the Chinese trial is accused of having a type 2 error, a false negative. Since 60 to 70% or more of 200 million Americans will eventually get COVID, remember, the virus cannot be stopped. It would be nice to have a clear answer on whether remdesivir has an effect. The viral load not being improved in the Chinese trial is peculiar because if the NIH trial has positive results without a reduction in viral load, I think that makes the chance of a spurious finding more likely. All right, now to some cardiology. One of the most dangerous things that can happen to vulnerable patients in a hospital is to have their QT interval prolonged. The QT interval is the time it takes for the heart to have electrical relaxation, and if it gets too long, the heart can start having early after depolarizations, which are medical jargon for rapid, ugly, dangerous, premature ventricular beats that can lead to death. This week, the FDA put out a warning on the use of hydroxychloroquine and chloroquine in the treatment of patients with COVID. Shockingly, and in a story that I think will be told in 8th grade science classes, many hospitals had codified the use of HCQ and azithromycin in their COVID protocols. The reason this will be discussed in science classes is because there was literally not a shred of reliable evidence for the drug's use. Our president suggested it, and a French study, which I have come to call an unstudy, because not only did it not have a randomized control group, but the investigators threw out patients in the drug arm that did badly. Nonetheless, equipoise was shredded and HCQ became standard of care. But this week, after numerous reports of non-benefit and harm beginning to surface, the FDA correctly, I think, updated a safety communication saying that the drug should only be used in trials or on an emergency basis when trials were not available. They also urged close supervision for QT prolongation. Okay, good. This turn towards common sense can be filed under the better late than never category. Next topic, ECG monitoring. Again, a cardiology topic. Steve Stiles has a superb report on ECG monitoring of patients with COVID-19. One of the reports from Canadian investigators is especially interesting. This was a small prospective case series of 22 patients in a QT clinic studied for a use of a single lead recording from a handheld ECG from the Cardia device, iPhone ECG, and they compared it to a 12-lead ECG. They published their paper in JACC EP. In full disclosure, I'm now an associate editor for social media at JACC EP. The Canadian investigators found that the QTC intervals could be measured reproducibly using a single handheld ECG in this group, but it required capture of multiple vectors with the handheld device and not just a single lead. The study confirms that lead 1 alone, and therefore the single lead cardiomobile used as originally intended, is unreliable for measuring the QT. It suggests that you should do a multi-lead, and that lead 2 might be one of the more useful leads for measuring the QTC. Interesting, though, Cardia now has a 6-lead ECG available from the device, and I think this will surely be better than just one lead. But again, I think before codifying use of handheld devices, we need more data. Indirectly related to COVID, I have found myself looking at numerous Cardia and Apple Watch tracings via telehealth visits. We have a decent-sized arrhythmia clinic of sotalol and dofetilide patients here at my hospital, and it would surely be nice to have 6-lead ECGs on them so that we don't have to have them come in for clinic ECGs. Handheld ECG monitoring makes the podcast because it offers a glimpse into the future. Next topic, a quick note on thrombosis and hemostasis in COVID-19. A colleague sent me a picture of a massive brain bleed in a young patient with COVID-19 who was placed on heparin for high D-dimers. It was a terrible bleed. Now, this doesn't mean we shouldn't consider prophylaxis or treatment with antithrombotics. And at the risk of sounding sophomoric, it is kind of no small thing to intervene in the body's delicate coagulation system balance, especially when it is immersed in an inflammatory storm. Patrice Wendling has a comprehensive news recap on recent society publications on treatment of vascular complications in COVID-19. I highly recommend this news story. Given the confusion and serious heterogeneity of this condition, I think the only answer are pragmatic RCTs, and lots of them. The good news is that we're dealing with a disease that lasts weeks, so we will not have to wait years for an answer. Final topic, and completely non-COVID. Let's talk about low surgical risk patients with aortic stenosis who have transcatheter aortic valve replacement. At the virtual ACC meeting, Professor Michael Mack gave a report on 2-year outcomes of the PARTNER 3 trial. Recall that PARTNER 3 was a 1,000-patient RCT, and it demonstrated superiority of TAVR with the balloon expanding valve versus surgery for the primary endpoint of death, stroke, or readmissions at 1 year. In the New England Journal in 2019, the results were 8.5% of the primary outcome in TAVR compared with 15.1% in the SAVR arm. That was highly statistically significant. However, Dr. Mack gave at 2 years data that showed the gap has closed. Now, the difference in the primary endpoint still remains statistically significant, but the gap was now 11.5% TAVR, 17.4% for SAVR, and that's a 37% relative risk reduction. In stroke, which at 1 year was significant in favor of TAVR, 1.2 versus 3.3, it was no longer significant at 2 years with rates of now 2.4 versus 3.6. Again, the difference in mortality closed, 2.4% with TAVR versus 3.2% with SAVR. Now, most notably, however, in this slide presentation, the cumulative incidence of valve thrombosis confirmed by CT or echo, 2.6% TAVR compared 0.7% with surgery. Most of these unwanted events came at year 2. So you all know the bottom line. I like TAVR. Gosh, this is a great procedure for certain patients. But the endpoint, especially when we're doing this in low-risk people, is no way 1 year. Younger, lower-risk people are not dying in 1 or 2 years. The endpoint for aortic stenosis patients who have lower surgical risk is 2, 3, 5, possibly 10 years. I look forward to this 2-year paper, but we must remain cautious about applying the current TAVR technology to lower-risk patients. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. I think over the coming weeks we'll see more and more cardiology being discussed here, but still, COVID is such a big story, I just can't ignore it at this time. Remember, if you like this podcast, please tell a friend, take the time to give us a review. It really means a lot and it helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.